Welcome to our panel discussion on reframing diabetes care from glycemic control to multi-organ protection and nephropathy and neuropathy centric, management, organized by Voice of Healthcare and supported by ECMS. Diabetes management is undergoing a fundamental transformation while achieving optimal glycemic control remains essential. Growing evidences highlight the need for broader patient centric approaches that prioritize protection of all the organs which are there in our body. Among these, diabetic neuropathy and nephropathy, they are one of the most common yet underdiagnosed complications, significantly affecting quality of life and also the mobility and also healthcare outcomes. Modern diabetes care increasingly emphasize early risk assessment, comprehensive cardiovascular, renal, retinal, neurological protection alongside the individual's treatment strategies. This evolving paradigm shifts the focus from controlling blood glucose alone to preserving functions, preventing complications, and improving long term health and well being. I have with me various eminent speakers. Join me in welcoming Dr. Bansi Saboo, Regional Chair, International Diabetes Federation, Southeast Asia, and Chairman, Diacare, Diabetes Care and Hormone Clinic. Welcome, Dr. Bansi.
Yes, thank you.
I have with me Dr. Professor Aditya Kapoor, Head of Department Cardiology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Welcome, sir.
Thank you, Dr. Manisha. Privileged to be here. Thank you.
Dr. Narayan Prasad, Professor and Head Nephrology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Welcome, sir. Sir, please unmute yourself.
Thank you, Dr. Manish.
Right. And we also have Dr. Priyank Modi, interventional cardiologist, Dr. Modi's Advanced Cardiac Care Center, Surat. Welcome, Dr. Priyank.
Pleasure being with you.
And we
What
have
was
with
the
us
processing
Ms.
link?
Arushi Jain, Director, ECMS Drug and Pharmaceutical Limited. Welcome, Ms. Arushi.
Namaste everyone, glad to be here.
So, Dr. Bansi, my first question is for you. That for decades, HbA1c reduction or blood sugar control has been the primary benchmark for successful diabetes management. However, growing evidence definitely suggests that achieving glycemic targets alone may not be sufficient to prevent long-term complications. How has our understanding of diabetes evolved over the years, and why is it now critical to move beyond glucose control towards a more comprehensive strategy, which is focusing on preventing our heart, kidneys, nerves, and overall patient well-being? Dr. Bansi, I think there is some network issue. So, okay. So I'll move on to Dr. Aditya. Dr. Aditya, we know we have been talking about the organ prevention, and I think heart is the most vital organ that's pumping inside our body, and cardiovascular disease remains the leading cause of death among people living with type 2 diabetes. So, from a cardiologist perspective, how has the recognition of diabetes as a major cardiovascular risk factor transform clinical practice, and what additional consideration should physicians incorporate when managing patients beyond blood sugar control?
Yeah, so thanks, Dr. Manisha. Am I audible?
Yes, yes.
I think that's a very, very relevant question pertinent to the discussion we are probably having today. And the biggest paradigm shifts, I think, in our practice has been that we no longer treat diabetes simply as a disease of high blood sugar. We treat it as a disease of, it's a multi-organ involvement. And in diabetes, what we often say, Dr. Narayan would also probably agree that every glucose reading will tell us only part of the story. Cardiovascular risk assessment will tell us the entire story. So if you look at the statistics, all of us know that probably 2 out of every 3 diabetics will eventually have a cardiovascular complication. So trials like the SGLT2 inhibitor trials, which we'll discuss subsequently, the GLP agonist trials have fundamentally changed our approach to managing these patients. So today the question, as you rightly said, is what is the patient's HbA1c was an older question. It has now been modified to what is the patient's overall cardiovascular, renal, heart failure risk. So we are probably moving from a glucocentric approach, I think, to a organocentric or organ protection approach. And every cardiologist, again, Dr. Modi will also, he is on board, he'll probably take the next question, that every diabetic should undergo comprehensive cardiovascular risk assessment, not only blood pressure, lipid profile, renal function assessment, but obesity, smoking, assessment for silent coronary artery disease, peripheral vascular disease, ankle brachial index we often forget in clinical practice, assessing for atrial fibrillation, and of course diabetic neuropathy, which we'll subsequently address in the other questions. So I think it's a multidisciplinary approach now involving cardiologists, endocrinologists, nephrologists, even the primary care physicians, so that not only do our patients live longer, but they live healthier. So the future of diabetes, again, I'll sum up by saying it's not glucocentric, it is patient-centric and organoprotective. So that is my
Right.
approach. Thank you.
Right. So, Dr. Priyank, it's very difficult to, make patients understand and make them assess their risk, what are there with the diabetes. So, in day-to-day clinical practice, many patients still believe that, controlling the blood sugar or having control HbA1c, that's okay for me. So, how can a clinician effectively communicate the broader risk associated with diabetes and encourage patients to adopt a more proactive approach towards protecting their heart and overall health?
Hi. So I really think we as doctors have only created this branding problem for diabetes by calling it sugar. So whenever a person is diagnosed for the first time where the HbA1c is on the higher side, we will say कि भाई साहब आपको sugar आया है. So from that day onwards, for that patient, everything for a diabetic patient, everything revolves around sugar. But we have to remember, as Sir rightly said, diabetes has very less respect for names. It does not raise your sugar, but it would silently age your blood vessels. It will silently age your nerves. As Sir said, like cardiovascular disease remains the most common cause of mortality in a patient with diabetes. You walk into any dialysis center in our country, and more than 50% of the patients who are undergoing dialysis there have actually landed there because of their diabetes. So, for us, we have to make sure that the conversation between a healthcare practitioner and the patient changes from just glucose control to end organ protection. It is our duty that we tell him that it is not your sugar, which is 400, is going to cause a change in your life or maybe an early departure from life, but it is the organ which it is going to affect, whether it is your heart, your nerves, your kidneys, your brain, your eyes, whatever it is. So we have to put it across to our patients that once you have got diabetes, these are something which we have to make sure that even 5 years, 10 years, or 20 years down the lane, you do not land up into the same. Now, okay, the second thing you described was about the proactive approach. Now, I don't believe that patients ignore diabetes because they really want to. It is the nature of diabetes that it is a very quiet and a polite disease in the initial years. You have to understand human brain is wired to respond to pain. It is not wired to respond to risk factors. And that is where, as Sir said, it becomes our job, maybe these forums where we need to create that public awareness that glucose is not a sugar problem or diabetes is not a sugar problem, but it is a problem of the whole body. uh, we have to be proactive in screening if we really want to prevent something. So we can do a lipid profile, blood pressure assessment. The patient has metabolic syndrome. We can check the weights. You have to understand diabetes comes in package. So it's not the patient is only diabetic. He's going to eventually have hypertension, obesity, dyslipidemia, everything. And that is the package we need to address because all our modern diseases are part of that broader aspect of metabolic syndrome. Uh, for heart, we can always we have good biomarkers right now to predict some breathlessness to be a cause of heart. We can do a good 2D echocardiography once in a while. We have CT calcium scores for patients more than 50 years to detect early atherosclerotic disease. Uh, a simple urine albumin ratio to make sure that before the creatinine rises, we are able to detect that early CKD patients. For nerves, maybe just an annual foot examination for diabetes, a retinal examination once in 3 years or after 5 years of the first time detection of diabetes. And I often call lifestyle as the fifth organ. So it becomes very, very simple when we ask the patient these basic relevant questions, that how many steps do you walk it per day? Do you cross that 10,000 wala forum? Do you walk for 150 minutes average in a week? What's your weight? Have you stopped smoking? Have you made those necessary changes in your diet that is going to prevent the progression of disease? So I think a very transparent discussion with the patient in the initial part when he is detected as diabetes will prime him for future. And why that becomes important, because previously the drugs which we had was only to control sugars. Either they were cardiac neutral or say it even harmed the heart. That is where all these new drugs had to undergo stringent cardiac protective trials. But now we have a lot of drugs which we can individualize based on what is the risk profile for that patient, what complications we are looking forward, and we can actually prevent that.
Right. So, as Dr. Priyank, you have rightly said that it's a silent disease and we are wired to, respond to something which is painful. So, diabetes doesn't announce, and maybe it'll announce when the organs are affected and, they are not functioning. So, my next question is for Dr. Narayan. As we know that nephropathy is one of the major complications. So, diabetic kidney disease often progress silently as well. So, why is it important to consider kidney protection as an integral part of diabetes management from the time of diagnosis, and how can early intervention alter long term patient outcomes?
Thank you, Dr. Khurana, for this very important and pertinent questions. Uh, as Dr. Aditya and Dr. Priyank has already pointed out, diabetes is not a single disease. It is a multi-organ disease, and we have been taught that this is a complex syndrome. We consider diabetes as a syndrome involving many more organs altogether. So we have been taught from MBBS that this is the complex, this is a syndrome, not a single disease. But important part is that you have asked me to tell about kidney involvement. So onset of the type 2 diabetes is never known when it comes into the picture, clinical pictures. So when the patients comes to you, by that time, many of these patients have already organ damage, particularly the kidney disease. Sometimes you will find the patient has the microalbuminuria, and that is the best time when you can detect that this patient has the early involvement of the kidney. And here you can target most of the therapy which has been evolved over the years, combining all medicines if if the patient tolerates, like we say about the four pillars of the therapy to prevent the progression of the kidney disease. Here, uh, RAS blockers, then SGLT2 inhibitors came into the pictures, then mineralocorticoid receptor agonist came, GLP-1 receptor agonist came. These pillars, depending on the patient's conditions, we can, here is the condition where we can revert back. Stage of the macroalbuminuria, where if you are able to control blood pressure with these RAS blockers, you can control glycemic controls, you can control hyperdynamic conditions and intraglomerular pressure. Nephrologists, I used to say that nephrologists control two kind of the pressures. One is the systemic blood pressure, that is the intraglomerular pressure. Intraglomerular pressure is very high, so you have to reduce this. Otherwise, filtration will go on and will injure the kidney. So here is the time when the kidney is functioning hyperfiltration stage. So there we can think of adding all the medicines to retard the progression of the chronic kidney disease. So that is the one important point. And the reversibility point is here. Once more than 300 milligram per gram of the creatine, albuminuria, microalbuminuria, this goes beyond that, then chances of the reversibility becomes minimal. And but still you can add on the medicines, optimize the medicines to retard the further progressions, but the reversibility pictures clinically it does not comes into the pictures. This is the reason why we always advocate detect early, and we always advocate those who, particularly in the type 1 diabetes, when the diabetes came into the picture, so there it is very easy to define 5 to 10 years onset. Then you can take uh, the markers for the kidney damage annually. But in type 2 diabetes, you never know. So at the onset, it is possible that some of the patients would have this diabetic kidney disease, would have the macroalbuminuria. So there we should target on. And then we advocate a little frequent follow-up of the macroalbuminuria if this is not there in the first visit, 6 monthly. But most of the guidelines say at least 6 months to 1 year. We must go on monitoring this macroalbuminuria and detect early and hit early, so that you can reverse the disease and you can retard the progression of the disease if it comes into the advanced stages. So this is the beauty of early detection, particularly when you are dealing with the patients of the type 2 diabetes, which is more common in our parts of the world.
Right. Right. So as we know that kidney complication is one of the commonest complication that can happen in diabetes. So what our experts are emphasizing that we should catch it early, especially at the stage where it is reversible, where the treatment, can be given and it can be halted, the complication. So my next question is for Miss Arushi. Diabetes therapies are often taken lifelong by patients with multiple comorbidities. What quality benchmarks, regulatory compliance standards, and in-progress control does CDMO can follow to ensure consistency, safety, and efficacy across every batch of diabetes formulation?
Thank you, Dr. Manisha. For patients managing diabetes lifelong alongside multiple comorbidities, quality is definitely a non-negotiable commitment at every stage of manufacturing. CDMOs can, deploy robust in-process controls, monitoring critical parameters such as dissolution profiles, the product assay, content uniformity, stability, from every batch to batch reliability. From for even more complex formulations, rigorous stability studies, compatibility, bioequivalence are fundamental to safeguarding the long-term product integrity. A risk-based quality management approach, also aligned with ICH Q10 guidelines, supported by thorough supplier qualification, raw material testing, CAPA frameworks, enables manufacturers and CDMOs to proactively identify and mitigate quality risks at the initial stages itself. And most importantly, I think overall CDMOs can play a critical role in upholding the quality by stringent global regulatory frameworks like WHO GMP, US FDA, EU GMP. Because whether it is for a diabetic patient or any other chronic patient, every dose must be as reliable as the last.
Right. I think every dose, as you said, that should be reliable, and if patient is taking that, there should definitely be, some benefit. And I think it should be so standardized that the quality part should be taken care of properly. And my next question is for Dr. Aditya. We know that more than half of deaths among individuals with type 2 diabetes, they are attributable to, cardiovascular disease, including the coronary artery disease, stroke, and heart failure. So, what are the key cardiovascular warning signs and risk indicators that physicians should proactively monitor, and how can every intervention improve both survival and quality of life?
So yeah, thank you, Dr. Manisha, once again. And I'll just pick up from where Dr. Modi left. He made a great statement about diabetes being a silent killer. So the most dangerous part of diabetes is not what you feel; it's what you don't feel. So often we have patients who come with a first heart attack or with chronic stable angina or acute coronary syndrome. So again, the thing is that we call it a silent killer because significant cardiac or vascular damage, or for that matter even renal damage, may have occurred before the symptoms become obvious. So, probably a good punchline for this particular question can be that the first heart attack or the first cardiac event should never become the first diagnosis of heart disease. So, you have to prevent it, you have to preempt it. And again, Dr. Priyank used a great line that one has to move from a reactive care to a proactive prevention. So again, proactive we all know is regular cardiovascular risk assessment, which we mentioned. Warning signs, which you say, the classical typical warning signs would be chest discomfort, breathlessness on exertion, unexplained fatigue, palpitation, dizziness. अगर किसी को पैरों में swelling आ रही है, exercise capacity reduce हो रही है, so all these are classical signs. But in diabetes, again, all of us know who are on the esteemed panel today that cardiac events can be silent because of diabetic neuropathy. It may blunt your pain perception. So any odd symptom, any unexplained symptom, including tiredness, sweating, nausea, this should never be taken lightly. We all tell our patients अगर ऐसे symptoms कई बार गैस के भी हो रहे हैं, so it should never be taken lightly because this is a sign of an impending heart disease. So again, risk indicators, we all know we measure blood pressure, the cholesterol parameters, renal parameters, BMI, body weight, circumference, smoking status, ECG abnormalities. We all look for that, surrogate markers for heart failure. Important thing which we often miss in clinical practice is assessing for peripheral vascular disease. I mentioned about ankle brachial index. It's a great thing to do in every clinic. Foot examination, evaluation for autonomic neuropathy, and इसके अंदर अगेन अब डॉक्टर नारायण है पैनल पे. सो इन डायबिटीज हार्ट एंड किडनीज आर लाइक बेस्ट फ्रेंड्स इन ट्रबल. So fortunately, so are the cardiologists and nephrologists. So it always has to be a teamwork because the kidneys will often whisper before the heart will scream. So listening together will save your patient's lives. So, so that is the key thing: multidisciplinary management, paying attention to what the patient says, and educating the patient about these symptoms. So the early intervention is not only about prescribing the right medication, it is also encouraging good lifestyle, which again Dr. Priyank mentioned as a fifth pillar. He said that's again a good thing to educate our patients. So again, a multidisciplinary approach. So the best treatment will be to prevent the first event, not to manage the second. So that is the key thing. We have to learn to understand that we have to prevent the first event, not manage the second complication.
Right.
Thank you.
Right. So moving on to Dr. Priyank, as we are discussing about the heart issues or heart complications which can arise because of diabetes. Sometimes what happens that heart failure is increasingly being recognized as a major complication of diabetes, even in the patients without established coronary artery disease. How should clinician identify patients at risk, and what opportunities exist to prevent heart failure before symptoms develop?
So Manisha ji, because Dr. Sir is not there, Dr. Banshi is not there, so I would like to put up two clinical examples where things are really different before I actually come to my answer, just to provoke a discussion maybe for later on. Both the patients are of today. So as sir rightly said, many times the patient comes to us with an MI as the first event. So today morning, a 38-year-old came with an anterior wall MI. We treated and everything. On admission, the sugars were 364 and then the HbA1c came as 11.5. So the patient's first diagnosis of a diabetic disease itself was an end event. So here we are talking big things about proactive care and prevention, but sometimes the acute stroke, like so many of our strokes come and the first thing is they never knew that they were hypertensive. And this patient was so casual saying कि हाँ 2 years before किसी ने मुझे कहा था थोड़ा sugar है, but then I was perfectly fine. So the first thing, because this is for general public, a lot of people are listening to us. If you are more than 18 years of age, or I would at least put it for doctors, any general practitioner, anyone who's into adulthood and is coming to your clinic, a blood sugar and blood pressure are the basic must, even if he comes with uh, cough and cold. Because if a person has come in contact with a healthcare professional, at least these two basic diseases should be ruled out. The second important aspect which will be relevant, so the second patient I did an angiography today, he's a 64-year-old guy, just retired, was into a corporate job, was diabetic for 20 years. Every year he's just taking metformin 500 milligram for his diabetes. Every year in the annual checkup for him, his sugars, like the HbA1c was 7 to 8, uh, and he was perfectly okay. So in post his annual workup for the company did not include a treadmill test. So he came for a treadmill, like for now the evaluation comes to a private practitioner like me. So he comes to us, I did a treadmill test, it becomes strongly positive, did a calcium score, it was 1500, did an angiogram, and it is triple vessel disease. So I'm putting it across, is the patient wrong? Because he was doing yearly checkup, he felt his sugars were okay, controlled. So that is the very important classical reason why we are all meeting today, why we have such like I would really like to thank you that you have given me a privilege to be alongside Dr. Aditya and Dr. Narayan, who are my teachers, in a perspective to share the forum. But that is where the patient never was wrong. Like he was taking a tablet, was not the sugars were not very high, and that is where it's not just maintaining the HbA1c, but 20 years of diabetes itself can cause a lot of problems, and that is where we have to be proactive in making sure that we detect something earlier. Thank you. Now going to the question, because I really felt these are the clinical examples which we really face on a daily basis, and they are so basic and so simple. So yeah, I did forget what you asked, but something about heart failure. So heart failure, I would put it across that like heart is the wife. So an Indian wife will only complain when she's really in trouble, and once she complains, then it is through the roof, and all we are guys here, and we know how difficult it is to manage things. So many a times, uh, like a patient would lose 30 to 40% of the cardiac reserve even before any symptom would come up. So he would just walk a little slow. He will avoid climbing stairs. He would put it across that this is because of normal aging, or maybe my lifestyle is too busy. I can't walk the stairs. I'll take a lift. But what actually they are doing is they are adapting their lifestyle to a failing heart. Now, uh, sir, rightly, as sir said, because of this neuropathy part, lot of ischemic event goes unnoticed as gastritis, and that is the reason a heart failure because of diabetes is often diagnosed late when the LV function is already reduced. So we as clinicians, we have to uh, stop asking about does the patient has heart disease, and we have to now start asking that is the patient's heart aging faster than the age of the patient himself. uh, and why this is important, because if we are able to die, so the best prevention of heart failure is preventing heart failure first hand. The two most common causes of heart failure, whether we call it as heart failure with reduced ejection fraction, where an ischemic event, or dilated cardiomyopathy because of microvascular disease in a diabetic patients, or even after hypertension, heart failure with preserved EF because of glycosylated end products, the elasticity of the heart is lost, and that is where heart failure with preserved EF is also very common in patients with diabetes. So early detection is helpful, because now, as in my first answer I said, we have certain tablets which can modify the disease. Like we have SGLT2 inhibitors which work wonderfully well. In all the studies it has proven to just not reduce the hospitalizations, but also cause a mortality benefit, and that is where the paradigm shift is there, and that is where early detection of heart failure in any patient with diabetes, particularly if they have other risk factors, so diabetes plus hypertension, diabetes plus CKD, diabetes plus proteinuria, diabetes plus dyslipidemia, uh, diabetes plus atrial fibrillation, all these substrates have a high risk of developing heart failure, and those are the patients we can be a little more aggressive in diagnosing in an earlier stage. So heart failure is not going to come on a Monday unexpectedly. It will keep on sending you those RSVPs. It is just those RSVPs we ignore.
I think what I want to assert here and repeat here is that every patient who is coming to a healthcare person, BP and sugar, these are the two things which should definitely be looked into, whatever may be the presenting complaint. Dr. Bansi, can you hear me? No, I think his network is still not working. So let's move on to Dr. Narayan. You had been telling
Oh, I
us
can hear
about.
you. I can hear you. Can you hear me?
Yes, Dr. Bansi, can you hear us?
Yes, I can hear you. And can you hear
Uh,
me?
yes, yes, sir. Sir,
Good.
we have been talking about various complications. I
Yes, I
want to
was
know
listening in between.
Yes. As we know that diabetes is increasingly being recognized as a systemic disease, now not as a metabolic disease alone. How should clinicians rethink their approach to risk assessment and patient management to identify cardiovascular, renal, and neurological complications earlier and intervene before any irreversible damage occurs?
So Manisha ji very rightly said, and we were discussing since long that diabetes is a systemic condition. It's a vascular disease. It's a disease of complication. But we were not having before few years a drugs which will be preventing cardio-renal complication in a person with diabetes. But now we have few drugs which are not only for good diabetes control but also for preventing complication. Our approach since last so many years is been changed is been changed in persons with diabetes, not for glucose control, but primarily for cardio-renal complication to be prevented and the multifactorial management of a person with diabetes. So each and every diabetic person who is coming to our clinic consider to have a other vascular problem, and our approach should be not only to have a good sugar control but simultaneously to control the complication. That's the only way. So now we have GLP-1, SGLT2 inhibitor, lipid lowering, blood pressure control. All these medications is primarily to prevent the person for cardio-renal complications for prevention. So our approach in a person with a metabolic syndrome is that sugar is just one marker. A hyperglycemia is marker, but they are going to have other complication, and we should use the molecule to prevent complication in person with diabetes.
Right, right. So, rightly said, sir, that we have drugs available, and now we should treat diabetes as a systemic disease. And definitely, the vessels are involved, they are aging fast, and we can definitely prevent the complications if we catch hold of the disease early and give the right drug. Dr. Narayan, you had been telling us about, albumin, urea, or microalbumin that can catch the kidney damage early. And we know that nearly 4 out of 10 people living with diabetes develop some, degree of kidney involvement during their lifetime. So tell us more about screening tools that can be, incorporated into clinical practice, wherein we catch the kidney involvement early on, say when it is reversible, as you were saying. Sir, please unmute yourself.
Yeah, again, very important and pertinent questions. Actually, before coming to these questions, I would like to highlight few important things like the legacy effect and critical window periods. So this is the one of the most important part, as everyone has pointed out about the diabetes control. So diabetes control is definitely, once you are not controlling diabetes, it is likely that this common pathway, pathogenesis of all macrovascular complication is basically endothelial dysfunctions causing some degree of the inflammation, hemodynamic problems, fibrosis. Some of these are shared between all organs, so that is very important. So legacy effect, controlling diabetes at the beginning is always very important and should be the most important part for any persons of the diabetes coming with any complications. So that remains with me. Why I am giving you some highlights here, because many of the patients coming to us long-standing diabetes. Now his diabetes is fully controlled, but he has multiple other complications. So why this happened so? This is when the patients on the same degree of the blood sugar, same number of the medications of the blood sugar control, developing hypoglycemia indicate probably you are developing kidney involvement. So one third of the insulin is metabolized in proximal tubular cells, proximal tubular epithelial cells of the kidney. So whenever kidney damage happens, sugar automatically gets controlled. And then there is probably the patient is in dilemma that probably our sugar is controlled, I am doing fine. So it is quite possible those who are developing recurrent hypoglycemia, we must think of probably your kidney is getting involved. So that is the one important information I want to convey to the general people. Other, as you have pointed out, told us to talk about this early detection. Microalbuminuria is the very early signs of involvement of the kidney. That is very cheaper kind of test. We can get it from any of the labs. Urinary albumin creatinine ratio more than 300 milligram albumin versus 1 gram of the creatinine indicate that probably your kidney is involved. So that is another other important test I would like to have every patient. Sometimes now condition coming non-macroalbuminuria, non-albuminuria chronic kidney disease in type 2 diabetes. So one thing I want to highlight that the concept of the microalbuminuria and other macrovascular complications came when there was not too much of these medicines in the era. Before 1990, you do not have these RAS blockers, we do not have SGLT2 inhibitors, we do not have this pindinone kind of the medicines. So during that period, no concept of the very tight control of the blood sugar. There was no concept you have to target HbA1c of the 7%, target BP of 130 by 80. That was concept was not lacking before. So what was happening? So these patients were developing all kind of the complications and macroalbuminuria. Now there is no albuminuria, but patient has kidney involvement. When you do kidney biopsy, you will see a lot of fibrosis is happening. This is the effect of the drugs. So non-albuminuric chronic kidney disease has relatively better prognosis. So it also might not be there. In that scenario, you must have the serum creatinine value, put on the CKD-EPI formula, get the eGFR, estimated GFR without any cost, getting only 50 rupees of, for the serum creatinine value, put on CKD-EPI formula, online available, see your GFR, continuously monitoring without any reason, fall in the too rapid GFR, that indicates probably your kidney is deteriorating fast, there is something wrong. So these two important investigations will like to suggest everyone to have one test for the albumin leak in the urine, and other is to go for estimating serum creatinine value and get EGFR calculations by this formula. So that will be the two important to catch up early and prevent progression.
Right. And these are simple tests. They are available widely in the diagnostic laboratories. And I think GFR, as Sir has said, and serum creatinine and microalbumin, these are the early tests, that can be taken for the diabetic patients to catch the kidney disease. Ms. Arushi, the management of diabetes increasingly require therapies that address multiple risk factors and comorbidities simultaneously. From a CDMO perspective, what opportunities do you see in developing patient-centric formulations and combination therapies that can simplify treatment, regimes and improve adherence by the patients?
Yeah. So what we all established is that diabetes affects is a multi-organ disease. It affects so many organs. So the future of diabetes treatment lies in integrated disease management, where therapies are designed not only to control blood sugar, glucose, but also to address these issues like the cardiovascular health, renal health, neurological risks simultaneously. So, for CMOs like us, this creates opportunities to develop patient centric formulations that simplify increasingly complex treatments, like technologies like triple layer tablets, where every layer is talking about a different, is targeting a different thing. modified release systems, fixed dosage combinations that enable multiple active ingredients to be incorporated into a single dosage form while effectively managing their separate incompatibility challenges. These technologies can help reduce the pill burden, improve customer dosing convenience, and ultimately enhance the patient adherence, which is very, very essential for achieving the long-term clinical outcomes in chronic diseases like diabetes. Apart from that, what is also important is that we focus on complementary categories like nutraceuticals, medical nutrition, and topical formulations that support a holistic diabetes management. So I think technologies like these can really help.
Yeah, right. So moving on to another complication that can occur, that is neuropathy, and it leads to mobility issues or pain, numbness, and other complications in the patient, and the quality of life is also affected. So if Dr. Bansi is there, I will ask him first. Dr. Bansi, are you there in the right network? All right. So I'll ask then Dr. Aditya. While we know that, sir, neuropathy is often associated with pain, numbness, and foot complications, and it can also have broader implications, say, for mobility and physical activity and overall, even the cardiovascular health. How does neuropathy contribute to overall disease burden and influence long-term outcome in patient living with diabetes?
So yes, so we all know that for diabetic patients, neuropathy is often underestimated. Most often, we just think of it as a symptomatic tingling, numbness, foot ulcers, but in reality, it is a marker of underlying vascular or even neurological damage, which has already initiated a vicious sort of cardiometabolic cycle in diabetics. So it's like a window into the health of the entire vascular system. And you yourself said correctly so that the first thing it will do is limit your mobility. So we all know that movement basically is medicine, but neuropathy will often steal the patient's ability to take that medicine. So when the patient becomes immobile, less physically active, there'll be weight gain, insulin resistance, hypertension, bad cardiovascular fitness, and this will initiate another vicious cycle which will further accelerate the cardiovascular, bad risk profile of the patient. The second more dangerous aspect is the cardiac autonomic neuropathy. So, damage to the autonomic nerves which regulate the cardiac function. It can lead to resting tachycardia, exercise intolerance, orthostatic hypotension, often abnormal heart rate variability, which basically means that the patient can be susceptible to various cardiac arrhythmias or ischemia or rarely even sudden cardiac death. So, because pain perception is impaired, many diabetic patients we spoke about it can have a silent heart attack, and this is, of course, more common in patients who have got autonomic neuropathy. Data has substantiated that guys who have got neuropathy will do badly. So, from a practical perspective, what we should be doing is that routinely assessing patient for symptoms of peripheral and autonomic neuropathy, performing routine regular foot examinations at every visit, ensuring structured physical activity within the patient's of course capacity, whatever they can do, and optimize the risk profile like blood pressure, renal parameters or cholesterol, etc., and of course appropriate sugar control. So don't wait for the patients to complain. Again, we keep coming back to the same thing, that it has to be a proactive approach for all diabetics rather than a reactive approach. So don't wait for the patients to complain. Ask proactively at each visit about numbness, burning feet, unsteadiness, falls, dizziness on standing, or reduce walking distance. And again, I'll come back to a good sentence which Dr. Modi spoke, that when we preserve mobility, we'll preserve our cardiovascular health. That is true for all of us, but especially so for diabetics. So in diabetics, every extra step which the patient will take is like an investment in tomorrow's health. So we have to educate the patient about supervised walking programs apart from the medications, of course. So good lifestyle, walking programs, cycling, resistant training, etc. So proactively looking for neuropathy and managing it well. So that is the basic key. Thank you.
Right. So my next question is for Dr. Priyank. with the increasingly availability of say risk prediction tools or digital health solutions and continuous monitoring technologies, how do you see that these technologies will reshape the preventive cardiometabolic care for patients who are living with diabetes?
Uh, so, sir had said, or I would, in the first question, we did say that I would put it across the future of diabetes. We can sum it up in just one sentence, that we are moving from reactive medicine to predictive medicine. So, for decades, we waited for complications to happen, a heart attack, a heart failure, a kidney disease, and then we treated it. But the next decade will be about identifying those risk factors long before any symptoms appear. Now, technology here would play an important role. You have those CGMS for continuous glucose monitoring. We have wearable devices which checks your pulse to detect atrial fibrillations, your blood pressure. Then we also have this AI-driven risk prediction scores, digital health platforms. Now, as doctors, we there are a lot of people who are very averse that know that these are all falsified data, they are irrelevant, because we are stubborn in a way, but we have ourselves gone through the same. Like Dr. Aditya sir would have seen the first generation stent where the restenosis was high, and now the fourth generation where you have to be at fault for the stent to close down. So similarly, any those AI driven risk prediction scores will have its flaw, but the way technology is really progressing, maybe it would be a very short while where the precision improves. So in a way, maybe with the patient together, we have to adapt to these things. uh, the only problem that technology alone will not be the future. The real innovation lies in converting that data which the patients have. Trust me, I'm a young guy, and a lot of patients consider me as their friends, and they will keep on my WhatsApp are just flooded with data from their wearable devices, that this is what I've got now, what does that mean, and what I should do. So the real innovation lies in converting that data into timely action. So imagine if you are able to tell the patient that your heart risk to heart failure is little increasing far before any breathlessness also. Leave aside the reports, but even before any of the symptoms would have happened, or your kidneys are giving you some early signs. As Dr. Narayan said, right now we have serum creatinine and urine albumin ratio to say whether you are at increased risk. But what if now we have this AI driven scores and everything which can predict it even beforehand? So for cardiologists, if we go, we have CT calcium score, we have some advanced echocardiographies, we have these biomarkers like a breathless patient, we can do an NT-proBNP, and we can combine that with AI monitoring, digital monitoring, and we can personalize the prevention rather than just get to the disease. So I would like just to put it across that the best heart attack, the best dialysis, or the best amputation is the one which never happened, and we have to adapt to technology to work together with them rather than against or for them, so that we can together come up with a solution which is scientifically proven. Then maybe like for the drugs, we can have trials on those algorithms to make sure that they really hold true in real life and they can actually make a difference in patients' life.
Right. And Dr. Narayan, we know that various complications, they present, collectively in a diabetic patients. So just to know that how do renal dysfunction and neuropathy interact clinically, and what challenges do physicians face while managing these complex patients?
Yeah. So usually, what we see in clinical practice that even diabetic kidney disease or diabetic nephropathy does not come alone. Most of the times, it comes with this retinopathy. It is a part of our examination protocol that whenever we see diabetic kidney disease patients or diabetic nephropathy, we ask for the diabetic retinopathy. So that is very common. You have asked about the neuropathy. Neuropathy is relatively, when we look at this incidence of the neuropathy, it is more common than nephropathy. Usually, it is seen at the first presentation when patients are coming to us in approximately 50 5%, 55 to 60% of the patients, whereas in 30 to 40% patients would have diabetic kidney disease at the time of the presentation. So all macrovascular complications, the basics pathophysiology remains the same. Advanced glycation end products with this uncontrolled diabetes, endothelial dysfunction, oxidative stress, some degree of inflammation. So affecting all. This is one vascular complications. Vessels is present all across the body. So affecting every organ of the body. Coming to the kidney and nerve loop, that is very important. Whenever you have decline in the GFR, some of the uremic toxins go up and they have very neuropathic potentials. So they will aggravate neuropathic symptoms too much. Some patients have disproportionate neuropathic symptoms. So that is the one important complication. But some of the uremic toxins are known to cause predominantly more nerve damage. Other important things comes to autonomic neuropathy. That is the one which is very much troublesome in day-to-day practice to control. What we say, cardiac autonomic neuropathy. Sometimes the heart rate gets altered. You have some degree of arrhythmia, sudden cardiac death happening because of this autonomic neuropathy is not uncommon in our
सुन
practice.
रहे थे कभी देखो
Suddenly
मेरे को
the
आवाज आ
patients
रही है but you are not able to see.
sometimes the patients on dialysis would have sudden death because of this autonomic neuropathy. So that is another important things we must examine in day-to-day practice about the autonomic involvement. Third important part that as already discussed by Dr. Priyank and Dr. Aditya about time and again about the foot examinations. That is really we see this examination, this foot involvement could be neurogenic, can be vasculogenic, can be both. And most of the times neuropathic, neurogenic and vasculogenic combinations factors are coming. And these factors gets further aggravated when you have the chronic kidney disease, you have the CKD MBD disorders. Vascular calcification is disproportionately very high in the CKD MBD, particularly in the diabetic kidney disease patients. Very difficult to control. Sometimes these patients have calciphylaxis, very difficult to control situation. So all these should be the part of the examination of the patient, whoever the physician see, whether this is the internist, whether this is a cardiologist, anyone, or a neurologist. They should all think of in total that whether this is a really what are the other different organs are involved at that point of the times. One scoring system that usually we do not do in day-to-day practice, I will say, and that was Toronto clinical scoring system is there. So that is called the popularly TCSS syndrome, clinical scoring systems. So that is based on this some scoring system from 0 to 19 points scoring system based on the symptoms, reflex, and then sensory examinations. And then you can think of it has been well established in 21-year follow-up cohort study. If your patients have the increasing score of this Toronto TCS scoring, then definitely the kidney disease involvement is going to be high. So that usually we do not do. It is very simple to see the reflex at the ankle or knee and can see whether this is present or absent on this getting at a score. Whether the symptoms of this tingling, numbness, and these things we ask, we can just score. So these scoring systems should come into the practice. And as Dr. Priyank was talking about, so now in AI times, you can develop your own tools and put empty markers, what is there or what is not there. You can have this one scoring system that will show. And it has been well established, long follow-up cohort study that if this scoring will go up, you would have the higher chance of developing cardiac problems or developing kidney problems. So that is another important other important thing I want to point out. When you have both chronic kidney disease and cardiac autonomic neuropathy, all cause mortality is 5 times higher. 5 times higher than when you have only one CKD or only one autonomic neuropathy, you might have the lesser two times all cause mortality. but when both are present, it becomes 5 times. So that is another important thing we must look into, whether your patient has both neuropathy or chronic kidney disease in type 2 diabetes patient. That we should look into. Definitely, it is a multi-organ problems, not a single organ problems. Thank you.
Right. Very well said, sir. So I think Dr. Bansi, can you hear us? My last
Yes, I am
question.
here.
Okay, sir.
I
So,
reached
so we have
hotel,
been
so I think now
right.
connectivity should be there. Tell me,
Thank
sorry.
God. So, sir, we have been discussing about, complex involvement of various organs, various complications, whether it's a neuropathy, nephropathy, or the cardiac involvement. Looking ahead, sir, what do you believe will define the next generation of diabetic care? And how can healthcare system transition from a reactive model focused on treating complications to a more proactive, model where the prevention, risk reduction, and preservation of organ that becomes mandatory?
So proactively, if you see all the organizations and if you see all the guidelines, we have become very proactive for managing diabetes complication. And our approach had become very clear. If you have just seen very recent guideline which has been published just before some time in 2026 American Diabetic Association, the guideline is very typical that now we are not to think that first line agent is only metformin. You think of person with diabetes, first you think that whether they have established cardiovascular disease or are they at high risk for cardiovascular disease or for chronic kidney disease. The same way that each and every person should be screened like CT coronary calcium score, urine for microalbuminuria. They are very important investigation for each and every person who is having diabetes, primarily to see that how many other risk factors which are associated with them, which they may have like dyslipidemia, high blood pressure, central obesity. So the weight management, the medicines which are for like Fintranon had come for the microalbumin or macroalbuminuria which they have, urine albumin creatine ratio is high. Or for CT coronary calcium score, think of giving them aspirin. You see the lipid guidelines, which is now talking of very aggressive lipid management. We were just before few years, it was just low, less than 100, but now the guidelines saying less than 70. And even if they are already established and high risk, then try to get the LDL less than 55 and use the molecule which is like GLP-1 and SGLT2 as a first line. This had become. But still, at a primary care level, this guideline, which we are talking since last 5, 10 years, slowly we are changing, but it is not reciprocated at that level. And this is what we have to do. So, I mean, this type of online meetings or reaching out to thousands of primary care physicians in India, more than 40,000 primary care physicians who are treating diabetes day to day. They may be having more than 10, 15 patients every day. So that approach by those physicians is very important in their clinic. That is what to be done. At present, still, they are glucose-centric approach. If any person come with a high sugar level, they just try to treat it with the molecules which is going to decrease the glucose level. But what's the purpose of just treating the glucose? Unless you are preventing diabetes complication, nobody is going to die just because of slightly higher sugar level with 200 or 250. Even now we are saying that if someone who is well controlled diabetes, like think of a condition, a person had gone or come to a clinic with a HbA1c level of 6.5 with a well controlled diabetes, with maybe on sulfonylurea, maybe on metformin or DPP4, but he is having high risk for cardiovascular disease, or he is a person with already CKM with a cardio or renal complication. Will you continue the same agent for diabetes control? No. We have to remove those agents, which maybe he may ask you, or the patient may say that my diabetes is well controlled. Why you want to change all those medicines? But no, that is not required because those medicines are not giving you any benefit as far as CV mortality is concerned, and that to be removed. And you have to add these molecules which are going to prevent or going to give the cardiovascular protection or the kidney protection. So these are very important messages. But at the guideline level, it has been changed because of last 10 years, so many data which has been published. But at the primary care level, still it is far away from their practice. Still, if you see the prescription, it is not changing so fast. But I'm sure in next 5 years, things will change slowly. If you see 2015, 2020, and 2025, things are changing slowly. In India, we are working very hard that these things should be changed very fast because now these molecules have also become off patent. So the cost of these molecules have become, which is everyone can afford. We were not able to write before a few years SGLT to everyone, but now we can write to everyone. Now GLP had become off patent, so probably we'll able to write more patients and we can give the benefits to more people with this.
Right,
Thank
right.
you.
On that note, I think the future is definitely good for the patients who are having diabetes, and we can definitely control the organ damage and control the complications with the help of various molecules that are available. With that note, I thank you all for joining us today in this discussion. Thank you.
Thank you. Thank you.
Thank you.
Thank you.